Welcome to Sports Doc Talk. Will Sanchez, along with our orthopedic surgeon and sports medicine specialist, Dr. Grant Garcia. Dr. Garcia, I started this conversation before we hit record. I'm going to have to take the AI function away from you because you are getting out of hand with your backgrounds. I don't know what's going to happen next show, but I
You have
know
no
that
idea.
you're having too much fun, man. How are you, man? What's going on?
I'm good. Things are good. Got vacation, recovering from time zone changes, and I'm really excited for our guest tonight. We're not going to give away too much of the spoils. That's supposed to be a shoulder above me, and that's some nutritional stuff. I go backwards this way, so I don't want to give away too much. We'll get into it in a second, but I'm really excited for this guest. This is going to be. We're trying not to nerd out too much with our shoulder talk.
Oh, God, please. You know we're going to get nerded out. You know you love it. Let's give a shout out to the good folks at the Recovery Shop. Let everybody know why you love
Yeah.
to utilize the Recovery Shop.
Yeah, so big thanks to our sponsors. The Recovery Shop's really great, and actually, our guest uses the Recovery Shop too, and actually sells some of the stuff on there we can talk about as well, which is great. So the Recovery Shop for me, for surgeons, it gives the surgeons the ability to get some patients these aftermarket things that they want. They want a little bit extra. How do I get better recovery with complete surgery nutrition? How do I get better machine options? They have those on there. Nice machines, you name it. Different products that are not available through the standard insurance processes. And my patients have been so enthusiastic. I mean, I had multiple patients today talk about the post-op recovery stuff they were able to do with something like the Recovery Shop. They were just really happy about it. It's a win-win for everybody. So reach out to Mike B at recoveryshop.com. Again, there's no cut from us for sponsoring you and sending you there. But the key here is really to make sure that your patients get what they need and that the surgeons feel like they can give their patients everything that ask for it. So.
Yeah, and it's not just the doctor saying it, it's the patient as well as someone that's recovered from a torn Achilles and utilizing that nice machine. It not only made my life better, but my wife's better. I've tell everybody that the fact that I did not have to bother my wife to go get me ice every 40 minutes as I iced on and iced off really saved our relationship. So if you can't utilize Recovery
Me
Shop for
too. Me
recovering,
too.
it will save your marriage. So it's one of the great things. Listen, I'm excited about our guest today. Recognized as one of the top shoulder surgeons in the United States, co-author of 2 books. I don't know how he does it. I'm going to bring him on because my first question is, Dr. Denard, thank you for being here, but how the hell have you done over 7,000 shoulder surgeries? Where is the time? Do you do anything else besides stay in the operating room? How is this possible?
Thanks for the introduction. Yeah. Efficiency, man. I just, I'm an efficiency monster and just try to prioritize. It's all about time management. A lot of people think I don't have a life actually, but I mean, I just got back from multiple vacations. I spend tons of time with my kids and, relationships. So, and do other things. So yeah, that's what it is.
There's no rumors that you have an operating room in your house and that's how you save time. You go to the room next door and start surgery.
I do 2 rooms. Yeah. Back and forth. Yeah. Yeah.
But not
I
in
like
this house.
in the zone. You stay in the zone, just flowing.
Yeah. I think that's a good point you bring up, because I think that people always say, Patrick, the same thing with, doing videos, and you do so much on your social media. You have so many publications, you're involved with industry. You do a really good job with the shoulder patients. You run your own practice at Oregon Shoulder Institute. So, it's a lot of things you're doing, and you have fellows. Is that correct? So, I mean,
Right.
you're doing a ton. And that's not easy to manage. But the key here is efficiency. We can get into this in a whole nother topic as to how, as a surgeon, you can be efficient and do so many different things at once. But I don't want to take away from all the awesome things that you have to talk about today. But really, really appreciate you coming on. I'm really excited for the audience to hear this. So this will be great. Can you talk to us? I mean, tell us a little bit about your background. I mean, Medford, Oregon, that's awesome. But like, you're now people fly in to see you from Medford, from all across the United States. People read your publications. Medford's a small town place in Oregon. Tell us why, how'd you do it? I mean, that's not there. I'm a big city Seattle guy. Like I had some work to do, but it's a different animal than being in Medford. How'd you do it?
Well, I grew up in a town called Zigzag. That's where I was born, 500 people at the base of Mount Hood. And then I moved to the big city of the Dalles when I was 5. I was raised there, a 10 to 10,000. So I'm a small town guy. I mean, like, I don't really like stoplights even.
And neither do I, but for different reasons.
Yeah, I just, that's just how I was raised. And so when I was looking to start my practice, I wanted to be in a medium-sized town. I was like, okay, medium-sized town so that I could specialize, but have a good quality of life. And, the other stuff just kind of came after. I mean, I always had kind of an interest, but to be honest, like probably in residency and fellowship, or medical school, I was doing some of it just to kind of get to the next step. And then when I did fellowship with Steve Burkhardt in San Antonio, I think that was a big sort of pivot in my life. And I sort of saw, okay, I can do this and kind of build my thing. And I just, slowly did it over time. It's just, I think most people underestimate what they can do in several years. Like they'll overestimate what they can do a year, but they will underestimate just with consistency what they can do over time. And that's really like my secret power is just time management and consistency. I'm just relentless about always trying to do the next thing and trying to build and make it better. So that's how it's gotten where it's at.
Yeah,
I will tell the audience this. I can tell that Patrick's incredibly efficient. I will tell you, of all the people we have emailed for our podcast, people I have reached out to, he is by far one of the fastest email responders. He is on top of it. For how busy he is, it was so easy to set this up with you. I mean, that just shows it, like, right? Like, you're everywhere and you're still available. And so the ability to do that can already, I mean, the minute I reached out to him, I knew that this was going to be, I could see the breakdown of how he works. And so it was kind of cool to see that because, I'm known to try to get my emails done quickly and respond well, but it's always like pulling teeth sometimes to get guests on here in terms of getting in touch with them, setting it up. Thanks. So I don't want to go off on tangent here, but thanks for making it so easy for me because normally it's not so easy. So I appreciate you.
Yeah, thanks.
So why don't we get into this? The conversation. I think you do so many cool shoulder surgeries. We just talk about your practice setup, like fellows and shoulders.
Yeah,
and
you got
just
it.
talk a bit about it.
So I do 100% shoulder. I've done 100% shoulder since I started practice. Probably 6 months into practice or a year into practice, I did 100% shoulder. So I started in 2011. I have a very high volume practice. I actually, believe it or not, I only at this point work 3 days a week. Yeah, I work Monday. I operate 2 days. I do Tuesday all day clinic, and I do Wednesdays I do 2 rooms. And then I save the other days for other things like the nutrition stuff we'll talk about, real estate investments, and working with industry and meetings, right, and research. The way I do that is I've just been really, prioritized trying to make every moment count. I have 2 PAs. They're great guys. They've been with me for 10 years each. So they funnel a lot of patients to where when I see patients in clinic, they pretty much have a problem or need surgery. So I don't see a lot of non-operative stuff. And then, that makes my clinic like I'm doing what I want to do, right? Is surgery or guide people whether or not they need surgery. And then I have 2 fellows. They spend 6 months with me each, and they rotate with 2 other guys in my group. So we got to, a busy group. We also have a research program. We do quite a bit of research. We usually have a visiting international research person or 2 who are doing a lot of work.
Did you set that up, the fellowship with them, or is that already established in place?
Yeah, I started it all. I started collecting outcomes, and then I got the fellowship, and I actually started doing outcomes, and then I got a 503(c)(b), created a nonprofit foundation so that I could bring in industry funding or grant funding. And had a good relationship with Arthrex. I can't ignore that. They really helped me kind of support my research at the beginning, which was really key for a guy in private practice. And I have 2 research coordinators who are full-time, who collect data. And I've been doing that just since the get-go. And then we developed the fellowship or started the fellowship 5 years ago now, I think. So, yeah, it's been a fun ride. What's fun is the satisfaction of like looking back and you built it, right? Like I had some opportunities at a couple of different points in my career to go elsewhere, and pick up and leave. And it was, you sit there and go through and, what do you want to do with your life kind of thing in the middle of your life. And I think having built it and feel like it's, I have a lot of autonomy and control, it's been really gratifying for me. because then I can start transitioning into, early in your career, what gets you really excited is doing surgery and doing it fast. And I still love surgery, but what excites me more now is teaching and research and development and trying to, move into that next phase, right? The whole like Arthur Brooks, like strength to strength thing, right? Like how you transition over your life. So
how did you get involved? What was the passion that you got into when you first got into this field? Was it something that as you studied, you decided to go into specializing in that specific area, or was it a mentor? I'm always curious. How does this happen?
What got you shoulder only? Tell us.
Yeah, shoulder. I mean, back medicine. I mean, I knew when I was like 15, I wanted to go into medicine. I was going to be a general surgeon because I worked in the operating room of the Dalles, and these guys would let me like scrub in and hold the camera and doing lap choles and sew with them. I was like, I'm going to be a general surgeon. It was so cool. And then I got to medical school and just ended up finding that my personality fit orthopedics more. It was actually a hand surgeon. I was operating with him, and I was like, this is just, I can see it, and I like see it get better. And it was just, I'm a very concrete thinker. Like if you ask me an analogy, like I will fail, right? Like every time, but I can think very concretely. So orthopedics fit. And when it got to orthopedics, just shoulder just seemed to be the field I thought was really growing, developing the most, really challenging field. But also early on, I really wanted to be a specialist. I just wanted to be like good at one thing. So that's how I got to shoulder and yeah.
And Patrick, I mean, there's a lot of people don't think about this. I mean, you've been doing this a while, but you're not, you've been doing this for 25, 30 years, right?
Right.
And it's a lot of work that you put in. I mean, to start a fellowship is already a big deal. Then be able to do a practice setup like you have, then if people flying in for surgery, I mean, that's a lot of efficiency. Who do you think, like, I mean, that's a pretty uncommon setup, right? To someone who's happy as you, who's as busy as you, but also doing all the stuff. Was there any guidance? I mean, we all know Burkhart, right? He's, one of the world's best shoulder surgeons, very involved with previous arthritic stuff and doing lots of sort of design and things like that. So he had some of that, but was there anybody kind of a template? Like in my practice, I'll be honest with you, my practice is a very big template of Cole. Trained at Rush. It was go, multiple rooms, very efficient cartilage practice. I do shoulder surgeries, elbow and knee, but that was kind of my kind of template. Was there any template, or you kind of steered off the course? I mean, there's not many people like you out there, but is there kind of anything you use as your template?
I think that, Steve was a really big influence. I mean, the reason I went and did fellowship with Steve was because he was in private practice. And I wanted to see that ability to do research and be involved. And like, I didn't know it was going to go, but I thought that seemed admirable to me. But I think I kind of take the philosophy of like the tribe of mentors here. And like the thing that I've noticed is that it's so accessible now, right? You can, Brian Cole is a guy that, I saw him speak when I was a resident. And I was like, I want to be able to present like that guy, right? Or like Tony Romeo is a great presenter. I want to present like Tony. And then, other people of like a Naval Ravikant, right? Like Naval Ravikant talks about, I'm a huge fan of his, and like, he has no idea who I am, but he's been a big influence on my life. He talks about things like, if you want to be good at something, or, let's take money, you want to make money, you should not do something that is below that pay grade, right? So just sort of using your time effectively. And he talks a lot about specialization, right? Like generalization is, the Renaissance man in many ways is kind of gone. You got to be really good at something, develop a skill. So I just try to take it all in, and like, I'm a big reader. I'm a big podcast guy. I'm listening to stuff all the time if I'm on the bike, and always trying to pick up new things and just try to, but yeah.
So this is that book of, I better book efficiency. I know that's the one different one. The one where it's just like the one line, it's like the arrow, you just go one way. There's so many different arrows going different directions. You just stay super hyper focused. And that's, that sounds a little bit like this. I remember Josh Dines over at HSS would kind of get involved with that book, and he was like, "Hey, you should read this." And I'm not as a vivacious reader as you, but that one was near and dear to my heart. But anyhow, I mean, will you talk about? So I know you do a lot of shoulder surgeries, and that's all great. You know, shoulder surgery is awesome, but I want to kind of hear more about. Let's pull up that rotator cuff slide. And I want to hear more about this, Patrick. I mean, because you're, like I said, you're the jack of all trades. You do research, you do really high volume surgeries, and you do a good job. But you're also involved in industry, so it's kind of the triple threat, which is unusual to find. So I know this is your paper. We could spend 200 hours reviewing all your papers because you've done so many of them. But kind of talk to us about what you're doing for rotator cuff thought process, and then we can get more into like the augmentation idea. So so listeners can hear this, because they hear rotator cuff, but augmentation, they're like, what the heck are you talking about?
Yeah, I mean, I think it's like, what we're trying to always do as clinicians is we're trying to calculate all these things, right, and get down to what is the best for the patient, right? So, and there's so many variables. So what we try to do here is give people a framework to think about when should you augment rotator cuff tears and not. Right. So that was kind of the big idea, is like, we have no guidelines. How do we get there?
25%. Patrick, will you describe the augment idea for the patients and listeners out there?
Yeah.
What's the idea of augment mean?
Right. So 25% of rotator cuff tears don't heal. We know that. So the idea is that they need something else, something like, biology. We'll talk about nutrition later, which I think is biology. But right now, as clinicians, we've maximized the strength of a repair of the biomechanics, right? So there's certain people that don't heal, and they need something else to augment. And that augmentation can be like a graft or tissue that you put on top of the rotator cuff. That augmentation could be things like putting in, growth factors, those kinds of things. Specifically here, we're talking about tissue augmentation, and we try to make a recommendation based on looking at patient factors going into the surgery that in advance that would allow you to have a conversation with the patient to say, hey, you're at higher risk, so now we're going to think about other things. Be prepared so you can be efficient when you're going to do it. Make the decision ahead of time versus like, we're human, right? We get to the end, like, do I really want to augment this case? No, I want to get out of here. But if I've made a decision ahead of time and said I'm going to augment, that's a big change.
Yeah.
And then I'm in private practice. The last thing is, I'm in private practice, so I have to think these things have costs, right? You mentioned industry relationship, they have costs. So I have to know what the insurance is, what the facility is, where I can go and do the procedure if I think it's indicated. So that was the idea of this paper, is try to give people a framework.
I think that's important for the listeners to hear, because we drop all this really cool technology all the time, but I think Patrick will completely agree. He's already shaking his hand. He knows where I'm going with this. But, insurance companies, it's difficult, right? Here's your pot for the surgery center. And if you start putting more fancy things, it's like a car, right? Well, you get your upgrades. You want your sunroof. You want your Apple Play. You want your souped up engine. Sooner or later, the budget runs out and you can't do the surgery, right? Yeah. And then the surgery center says, you can't do this. This is too costly. And it depends on the insurance company. So it is troubling and frustrating, right? Because if we didn't have to worry about that, we could augment everybody. I mean, honestly, if it wasn't for the insurance company
come back and say, we're not paying for the surgery and you're out and the patient is out. I've had that happen.
And they're just, that doesn't go very well. That's not a good conversation. So that's even the last piece of the puzzle. When you're augmenting, what is your so the idea behind this, for Will listen, I don't know if you have any questions, but basically, you got a rotator cuff tear, you fix it, but now you got to add something extra like you talked about. So you've got biologics, you're going to add post stuff, surgical nutrition, we'll get to in a minute. What's kind of your go-to? Like, what do you like to do? Does it kind of depend on the situation? I know, again, we're not going to go into crazy nuances. The subscap, irreparable subscap, that stuff's important, right. But really kind of, and most of the time, how often are you adding something else intra-op when you go in there and see it? Or you, like you said, you have that plan ahead of time, you've seen the MRI. Like, what factors are you looking at? You got all these things, but is the MRI the most important for you? Is it the patient that's most important for you? Is it just like your gut feeling? Like, how are you doing it?
Yeah, I try to look at, most of the scoring system, the rotator cuff healing index, was this ROHI score, is based off the MRI. It's based off of age and the MRI, right? The MRI findings. And I think that's the most objective way. If you look at the time of surgery, you're probably not as good as you think you are in really deciding.
Yeah.
The exception to that would be like, I really don't care what it looks like. If it's revision, even if it's small, I'm gonna augment. But to answer your question, I probably augment about 10% of my cases. A lot of people think it's a lot more. I told you 25% don't heal based on the data. And the fact there though is that in older patients who are lower demand, if they get partial healing, that's probably acceptable.
Yeah.
So if I have a 75-year-old who has a tear that may have a ROHI of 7, I'm probably not going to augment because they're going to be okay with partial healing. I'm really targeting.
Also, we also know some of those patients that you do the augment that they don't heal and they don't have a pain. Like you said, the partial healing, they may not even be symptomatic.
Right. Not all. Right. Exactly. That's the point. It's like not all, just because they don't all heal, still the vast majority of patients do well, right? Like 90% of people are going to do well from a rotator cuff repair. Yeah. So it's really those young ones I think you're trying to target to alter their natural history, because in them, lack of healing is not acceptable because they're going to go on to have, early arthritis, et cetera. Right.
Yeah.
And they're higher.
Patrick, are you doing any more of do you do any of the tendon transfer stuff? Are you mostly cuff augmentation? I know you do a lot of shoulder arthroplasty.
Yeah.
What's your thoughts on that stuff?
Yeah, I do 300 arthroplasties a year, right? Because it's all shoulder and about 300 cuffs and then a smattering of other things. So I do it all. I do tendon transfers. I do some, cable reconstructions for irreparable tears. Do all sorts of, and really to me, it's about trying to define the right patient for the right indication rather than everything being a hammer as a nail,
Do you, are you doing ever biologics for your rotator cuffs? Do you ever add that, or what's your thoughts on that?
Yeah, I offer all my patients PRP, and we do that in a cash pay model at the surgery center. I say, here, the data says support for healing. It helps with healing, that is. It's probably about a 10 to 15% difference. It's not going to take you from 30% to 90% chance of healing. I would have it. If you want it, you can pay for it. And we give a low price point to do that. We also offer BMAC in the same manner. And
BMAC is bone marrow aspirate. Everybody listening.
Yeah, just a higher concentration of growth factors. I don't like to call it, stem cells. That probably is misleading. But as far as augmentation though, if somebody has, maybe a good chance of healing and they just want to make it a little bit better, PRP is perfect. But if they have a low chance of healing without arthritis, that's where I start having the conversation about augmentation. My go-to is dermal allograft. You basically have xenograft, which is animal, right? You got allograft, which is skin from humans, and then you have synthetic patches now emerging in the market. So I'm doing primarily dermal allograft and a little bit of synthetic patches in some cases.
Yeah, and for people to hear, the skin's pretty interesting because there's plenty of biopsy studies that show actually the blood vessels go through the skin and actually heal it pretty well, which is pretty impressive.
Vascularization, right?
And not that we want to say they fail, but if you ever take one out, they're actually extremely difficult because they heal right in. That's kind of socked down.
It can
be. If you get a good healing response, which is impressive.
Yep.
So
you're right.
Yeah, I was going to ask real quick, just the complicated ones where, let's say, a patient is older, has an injury, maybe for whatever reason they live by themselves, so they really have to take care of themselves and do the shopping. How are those decisions compared to a normal procedure where you go, well, this is what I will do for this patient, and you have to consider maybe the quality of life that this person is going through as far as the repair, if you can take, which is impossible to do, the insurance aspect of it, the money aspect, just how hard are those decisions? And do you consult with yourself, the team? How does that work?
Yeah, there's a lot that goes into that, right? You might have somebody who actually has a tear that's kind of borderline, but you might say that, they're 75 or 80, and I might do a shoulder replacement because, you want one and done, and you don't want to put them through 6 months, have it not work out. Yeah. Maybe even if it's only 1 in 3 that it's not going to work out, but if it doesn't, then they have another 6 months of recovery or plus. So those are absolutely decisions that, are factors that go into play. The other one is, I call it the trilogy of demise, right? It's like poor bone quality, poor strength, and poor attitude. And, I can tell within 30 seconds, and I'm sure Grant can as well, who's going to do really well and who's going to do really poorly. There's like they're the far sides, right? If they have good strength, good bone, good attitude, you're like, you're going to do great.
Give me more of those.
You got everybody in the middle, right? That you're trying to like do the best you can, but you get to people in the end, it can be really, really hard.
Yeah. And that's also, Will, sometimes when you change your method, right? Like you get a patient's like mid 60s, late 70s, they got a poor attitude, they've got both biologies on the fence, and you just know there's no way they're going to handle a rotator cuff with augmentation. It's just reverse, because it's just you got to get in the best shot, and it's just that's one and done, and you can't do, and you do such a good job with your replacements that it's kind of like. The other thing is, the nice thing about someone like Patrick, and I'm sure I want to go on to the next topic, but is because you do all those shoulder things, someone doesn't feel like they're stuck with it, right? Like I know a lot of guys in the area, they do just the cuff stuff, or they don't do the shoulder arthroplasty. I do like the whole gamut like you do. So you can offer each step. So you don't have to feel like, okay, he's not giving me the best option because he doesn't do it. And I think that's a really important thing. That's where I think the specialization, I actually call it now super specialization. Like a guy like you would be kind of super specialized, like just shoulder, just high level stuff. Can make a difference to the patient. That's what patients don't get. You see someone does shoulder, it doesn't mean they're doing all the shoulder stuff.
Right. Yeah. Well, patients still go to people based on proximity and convenience a lot, right? My busiest year in practice was COVID because we only had 6 weeks off here, and then I didn't travel. So, and I was just available. And so people would come see me in the office, and, we didn't have much of a shutdown. It just really showed me that I'm like, I'm not that big a deal to most people out there. It's just because they can get an appointment next week. That's how a lot of people make decisions.
And you make that decision with PT also. When I'm going to look at a couple places, and if they're comparable, I'm going to the closest place, kind of piggybacking on what you're talking about. Not saying specifically you, because you have a specialist, but I know when it comes to PT, if it's convenient for me and I could get to it quick, I'm going to choose something that's close.
Will, we got to move on. I told you this was to have with Patrick. I'm going to be in control of this situation. Go to that next slide. Show about the Remplissage. I want to talk about the instability briefly, because Patrick does more than just this, and we got to get to surgical nutrition, because this is going to be, to go to the next one. I mean, this is a good one. Why don't you bring this up briefly? We'll jump into your nutrition in a second, and then we'll pull up the shoulder stuff. So kind of go over what's your thoughts on this.
We were talking about we talk about biology, and what's interesting here is this study recently out of Japan. They looked at nutritional risk, and what you see here is that people often underestimate how good their nutrition is. So first thing you see is that actually about 50% of people or more have some risk of nutritional deficiency. Interestingly, when they looked at like all the factors, their nutritional status, if you look at the odds ratio, it was higher or more important than tear size or age and fat infiltration, which is what we talk about the cuff. So I just think when we're talking about biology, we cannot not be talking about nutrition as well if we really want to optimize the patient.
And as a surgeons, right? I mean, you're very nutrition heavy, but there's not everybody's like that, right? So we're like, go, fix, yes. Cuff patch, biology, PRP, and we totally forget about this. And I've talked about this before, but like, that's why like the recovery shop, but that's why like the post-surgical, the pre-surgical, those are very important. And as surgeons, we're not very good at that. You are, but not a lot of us are.
Right.
About thinking about this stuff. So it's really important, I think, we bring it up.
Yeah.
So we'll bring up this. So you do you have your cuff patient population, right? That's your sort of like, 50s, 70s, and you got your shoulder arthroplasty, your 60, 70. Again, this is a generalization. There are people that fit in all categories, but you got your young athletes, right? And this is actually something that you are known for as well, is your shoulder instability patients. And this is something that I like to specialize in as well with this sort of stuff. So can you I mean, this is a very nice color chart. I know you just made it up and it's not from a paper of yours, but I've definitely, like I told you before the audience, I've seen this plenty of times. It's a really nice thing. Kind of just briefly discuss what this is, and this, you talk about a couple of the things here, and to talk about Remplissage or whatever else.
Yeah. So when you're looking at people who dislocate their shoulder, you have to know who they are, like what their risk factors are for having repeated dislocations. Specifically, that's going to be young men under the age of 20, 25, right? Everybody talks about bone loss, and we talk about how much of the socket or glenoid you've knocked off, because it's like a ball in a golf tee. Once you knock off some bone, it becomes very unstable. So we talk about, do you add bone graft? The point of this algorithm really is to say there's this category of people who don't have a lot of bone loss, and a lot of surgeons will still do a Bankart repair. And my argument is that if you look at isolated Bankart repair and look at the outcomes, they do well for a couple of years. On average, the failure rate's about 8%, but they continue to dislocate out to 2 and 4 years. So you start approaching a redislocation rate of about 20%, which is 8% is not acceptable, but 20% is certainly not acceptable when you go out midterm for these patients. So that's where I basically have said, even with low bone loss, almost all cases I'm adding a Remplissage, because if you look at high risk, that's somebody under the age of 25. You got a 25 or 18-year-old male. I don't care if they have a little bone loss. They are very high risk. They dislocate a normal shoulder. They've already shown that. So everybody talks about this glenoid tract stuff. I don't care about the glenoid tract. I add Remplissage. And the reason is Remplissage helps pull the shoulder back biomechanically. Very clearly, it shows the dislocation rate drops. Our outcomes, 2 years, our dislocation rate was 8% with isolated Bankart, 2% when we had a Remplissage.
Yes.
And other studies have shown that not only that, but you don't have that continued drop off between 2 and 4 years. It's like the Remplissages tend to do well mid to long term. So we really done a lot of Remplissage, and it's just become easier with the techniques with knotless anchors, and that's honestly one of the reasons we started doing it. Is just got easier. I was like, all right, and then we looked back and found that it really made a difference in the outcomes.
And for people listening, I mean, if you look over here, it's hard to see, though. Maybe if you're on your phone to see the sort of breakdown, but this less than 15% bone loss is actually a very common patient population. I mean, I would say in my office, it's probably one of the most common. Would you agree? Yeah. And if you look here, more than one I mean, I get a lot of first-time dislocators from some of the sports teams I do, but it's not frequent that I'm getting a single dislocation patient as often as I'm getting the multiple dislocation.
100%. Yeah, I agree with you. By the time they've got to you, or honestly, if they have a single dislocation and they're 17, 18, they have any Hill Sachs, which they should. I'm going to add Remplissage most of those patients, because the data is so profound, the differences.
Well, and it's so for the listeners, the Remplissage, we basically take part of the rotator cuff in the back and we attach it. Now that sounds kind of morbid, but I mean, Patrick, what do you think now with the new techniques? And we'll get into kind of futuristic stuff for this. The Remplissage, what do you think? How much longer does the Remplissage take you from a surgery standpoint?
Oh, 3 to 5 minutes. Yeah. It really doesn't add much with the techniques we have now. And that used to be a big ordeal. When I was in fellowship, it was like a 30-minute thing. It was like, oh my gosh, we got to do the Remplissage. It's way easier now. Just doing it in through one cannula right above, so we can just link the anchors knotless and the real question, like, why not, right? And you would say, why? You're worried about, time. Well, time's gone. There is cost. Okay, cost, sure, but I'm going to try to do the right thing. I'd much rather suck up a few $100s for a couple of anchors than have the patient redislocate. We worried about loss of external rotation. The data doesn't show that bears out.
I think that's perfect. You just did a study on that. Can you talk about that? Because that is the number one thing that shoulder surgeons tell me, right? Yeah. I say this word about, I love Remplissage. So the idea, Will, is if you attach the back of the shoulder, there are some older data that shows maybe you'll lose a little bit of range of motion. And obviously people are like, then why would you add it, right? Like anybody wanting to be a skeptic of this simple additional surgery is going to bring that up. So maybe you could bring up that briefly.
Yeah, we just did a big review looking at all the world's literature and found that actually when you compare Bankart and Bankart with Remplissage and Latarjet, there's no difference in loss of external rotation. If you think about this, what's going to lower your external rotation is tightening anteriorly. So you're often going to get some slight amount of external rotation loss with a Bankart repair because you tighten the capsule. You have to make it tighter than it was. but the back doesn't actually do anything. It's not stopping you, doing work in the back doesn't stop you from externally rotating, provided you're getting a good view, you're doing something anatomic, right? It's really not going to limit you.
Well, and I think that's important. What you brought up is, again, you do a lot of teaching. You and I both work with, we've talked about this. Will doesn't want to get too excited about internal brace with Arthrex, but nonetheless, you and I both work with them. And, one of the things that we're trying to do is to make the surgery easier, right? Because, like, no offense, but you saying 3 to 5 minutes and a random guy that does 2 a year is not going to look at you and go, well, I don't really care. 3 to 5, good job, Patrick Denard. You do like 100 of these. So we got to find a way to make it more, I think that's where the future is, right?
Yeah, it's gotten a lot easier, but we need to keep taking steps forward to make it even more reproducible.
And I think that's the nice thing about, I think that's nice thing was you talk about, you got your time for the industry. The idea of the industry is that, can we find a way to make it so that you coming off, not maybe, no offense, maybe Will could do Remplissage, but so we can have all of us doing, maybe, who knows, he could play doctor on TV. But the idea of having these guys that are community doctors that do a few shoulder surgeries a year, 20, 30 shoulder surgeries a year, being able to do a Remplissage to get the patient, because I think that it's hard I probably want you to explain this better, but how much does it suck to have a redislocation after you just did a labrum repair?
So
you haven't had it, but I'm just saying, explain to the audience.
Yeah.
Why is it such a big deal to stop it?
So the thing is, like, it's the patient, right? Because it's the surgery that bothers me the most is instability, because you have a young individual who's like their whole life ahead of them.
Mm-hmm.
So they're playing sports most of the time. And when they redislocate, you're just like, oh man. And you got to talk to the parents, and they got to go again and do something, and they they go through this psychological response. They dislocate and you fix them. And then if they dislocate again, then they're changed for life. There's actually changes that happen in the brain as a result of this. So that's the one that keeps me up at night. So the fellows, like, they don't get to do anything in the instability cases, right? They are there to watch those cases, because it's just, I feel like the most is on the line in those situations.
I've noticed that as I've gotten more in practice, I do more anchors now. I'm more careful, and I'm adding more Remplissages, because, like you said, I can't handle I can barely handle a 5% redislocation rate in my anterior labral repairs. I mean, I early on in practice thought I was so good at the anterior labral repairs till I got a redislocation, right? Yep. Everyone thinks they know what they're doing. They're straightforward. They're comfortable cases. Yep. We're in a flow. It's like playing the piano, right? And then you do an awesome killer 4 anchor repair and they fail. And you're like, I don't know what I did wrong, right? And it's the exact same thing. And now I'm doing the Remplissage. It just makes me feel better. It's just this whole thing about and then your papers now, I can quote them and say, there's no loss of rotation. And my question, I guess, to you is, other than, I guess people can say the costs or challenge, why would you, this is going to be like the LET for the ACL, right? The ALL, my question to my patients, I got 4 people indicated for LETs today. Why would you not do the Remplissage?
That's exactly. Why not, right? Yeah.
Yeah, I want to piggyback on something that you said, and I know it'll resonate with folks listening. I've coached multiple sports: football, baseball, basketball, and as a parent, as a coach, seeing what that athlete goes through when they get re-injured with the same injury they had, besides how the parents feel, the going through it all over again mentally for these kids, the trauma, the lack of confidence. Can they do it again? That whole process is not just starting over, but you're starting way over. And it's not just recovering from the injury, but now recovering mentally, depending on what your lifestyle is, spiritually. There's so much going on, and there's so much work that it takes a community to relift. Most people, other people have resolve, right? But the majority of the cases that we've seen with athletes getting hurt, whether myself and other coaches, it's detrimental. So I can imagine, and we don't think about it from your perspective, right? We think about it as a parent or a patient or a coach or something like that, that you're going through this trauma as well. And it kind of all makes sense when you're saying, if we can do something to reduce that, why wouldn't we do it? And it resonates what you guys are talking about.
Yeah.
And I think as the audience listening, I mean, that's what you should be asking your surgeon. Why are we not? Right? You told me I had dislocation. You told me I had a Hill-Sachs lesion, and then you're just going to do a basic repair of my labrum. And no offense, a basic repair. It's still complicated. But, you know, like I said, we should start looking in the back of the shoulder. You make sure you get that posterior sling. Sometimes those are off. Making sure you're adding Remplissage and know the order. And again, for the surgeon listening, the first few times, yeah, it's going to be weird, right? There's an order to it. At least that's the way I do it. Maybe different from you, but you know, there's an order to it, and there's a little bit of an art. And 3 to 5 minutes is what you'll get down to when you know what you're doing. But you got to do it. I mean, you just and nowadays, right? It's one of the best arthroscopic procedures we can do, because we can do these bony procedures through the scope, but they're dangerous, they're hard, it's really challenging. And the idea of doing an open Latarjet is it's got its own things, but the fact is nowadays we can get away. The Remplissage, it's both spectrums, right? It's the patients with less bone loss, and even the patients now with a little bit more bone loss, we've seen the equivalent results. And so it's got such a broad range that it really should be like a Remplissage, or do we big enough for a DTA or a Latarjet? Right? That's really the kind of the gamma we're at. And that in that Latarjet DTA group, I feel like keeps getting pushed bigger and bigger and bigger, and the Remplissage is filling the gap. Would you agree?
Yeah, no, I'm with you. I'm with you. My only ones are the wrestlers, because they're just crazy. They just put their arms in the craziest positions, and like those ones, I'll lower my threshold and I'll do a Latarjet. But that's
I had a guy I did a Latarjet on. He's a motocross. He said, I will not stop doing motocross.
Oh man, yeah.
Oh yeah, the wrestlers are good.
Totally agree. I mean,
how about rugby for you? Is rugby the same threshold for you, or is it?
I don't have a lot of rugby people. I mean, Southern Oregon is big in wrestling, so it's like it's the random sports that everybody plays football. You know, I mean the standard sports, but then like wrestling is really big in Southern Oregon. So those are my high risk individuals.
Can I follow up on a question there? Are you seeing any significant injuries when it comes to wrestling with football players? Usually the season is football in the fall, and then going into winter, you go into wrestling. Are you seeing anything, talking to patients, say, well, my shoulder was sore while I was playing football, and now it got exasperated, and now you have a bigger injury when it comes to a wrestler that plays football?
You know, I haven't noticed a ton of that, because most of my wrestlers down here are they're like year-round wrestlers. They're serious. Yeah, so I haven't noticed that like transition from football to
we used to see a lot of that back in the tri-state, New York, New Jersey, Connecticut, where you had the football players, the offensive linemen, defensive linemen, linebackers play football, and it goes right into the winter sport for wrestling. And there would be a lot more wear and tear for these players. So I was just curious to see if you had
definitely, you know, this data that shows that if kids don't get enough rest, they definitely have a higher rate of injury, especially if they're doing one sport all year. I mean, that's another thing, right?
All right, I don't want to cut off Patrick. We got to get to his last piece, which is everyone's trying to figure out why I've got pills on one side, a spoon, and this thing that says complete surgical nutrition.
We thought you had issues. Okay, no, I
might. I think ChatGPT, I'm going to blame them. But can we pull up that muscle loss after surgery? Patrick, so you already told us how you're the jack of all trades in the nicest way possible. But you keep talking about this complete surgical nutrition. Talk about the importance of nutrition. Brief background. I know we only have about 17 minutes left, so sorry to make this so much shorter. But will you talk about this and how this came to be, and now you've got this awesome thing you work on, and
Yeah. So when I was in high school, I was an athlete, and I was doing supplements, and I started taking creatine, and that time that was crazy, right? I was like reading Bill Phillips' Body for Life about HMB and leucine and all this stuff, and just always had an interest in it. And I started early in my practice, you know, telling patients to take vitamin D, vitamin C, because I would read articles on it, and like that makes a lot of sense, and patients liked it. And then over the last probably 5 years, I really just saw the data on protein. And, you know, everybody goes through this period where after they have surgery, they have muscle loss. And, you know, you're going to get that slide disuse. And so we're going to go through this period, you know, whether it's a mobilization from a sling or, you know, a brace for the knee or a cast. If you've ever seen me for cast, they come at it and they look cachectic, right? They look like a skeleton basically. So concept here is if you can intervene nutritionally, you from a muscle standpoint, you're not going to take all that away, but you can lower the recovery curve, right? You can make the recovery faster.
And that's the green for people who can't see. Is that correct?
Exactly.
That green line?
Intervene nutrition. And when you're looking from a muscle perspective, there's a lot of factors, but the biggest thing is that your protein requirement doubles after surgery. Most patients get about 30% of their protein requirements after surgery. And specifically, when you talk about amino acids, the most important amino acid, there's many that are important, but the most important amino acid for decreasing muscle loss is leucine. And you need about 3 grams of leucine per dose. Most over-the-counter protein products that you can get like Costco or whatever, you're going to get 1 gram to maybe up to 2. But the data on this looks at 3 grams of leucine per serving. That's where you really make the big difference. So you have to have overall increased protein intake, and you also need to specifically have high amounts of leucine if you're going to recover faster. And it's not just healthy or older individuals. Older individuals are more affected because, our muscle loss occurs with aging. But there's data showing that young, healthy adults, you bed rest them, they get muscle loss. If you supplement them with leucine, they get much less muscle loss. So it's not, it's like me and you are at risk, right? It's not just the 65-year-old, it's everybody. It's another one where you'd say, why not? So I recommend nutrition for everybody.
Is there any downside, Patrick?
Post?
Oh, sorry.
No.
Go.
There's really, that's the thing. There's no downside. I mean, I'm not recommending people are taking anything wild. It's increase in vitamin D intake, good for muscle and bone, increase in their protein intake, high in leucine, vitamin C helps with pain, helps with also tendon healing based on some studies as well. Magnesium, there's simple things, but as a society, we eat very, very poorly, right? And we think we have much better nutrition than we do. So, I've just taken the opportunity to try to lean into some of this and try to help my patients get a little bit better by focusing on this. I give them a lot of information about why nutrition is important. I do have my own company, like you mentioned on this, but I offer all my patients information. So, and many of them will just say, okay, I'm just going to go buy vitamins and get protein. That's fine. As long as they're doing something that's taking them forward, and some of them even, they even say, come back and say they really change their perspective, how they eat in general. So you maybe make an impact beyond the surgery, so I think it's been a really good thing, but the data is really clear. It's across all specialties.
Show that one, Will, the next one.
Yeah, it's not just ortho. I mean, there's data in colorectal surgery. There's cardiovascular surgery. This is a study on total knee arthroplasty supplemented with amino acids for 4 weeks after surgery. What's interesting about this study, randomized controlled trial, is that patients they did better in other terms. But this is strength. And what's interesting is those that supplemented, they did better at 2 years as well. Okay, that was the big difference in strength. They had earlier outcomes that were better. But what's interesting about that is it's not like you're going to, what this would say is that you're not necessarily going to get there eventually regardless. It would suggest there is a critical period you have to recover in which if you want to get to the ultimate best spot, right? So I think it's really important that we're talking to people about these options so that they can not only recover faster, but get to the best possible outcome long-term, as you're seeing here.
So I have a question for you on this one. So this is a really interesting point. I had 2 patients today brought this up. I was talking about, myself realizing I got injured and had to recover and realized I was kind of down still after a year. When you don't realize, people always say, like, I always say this first 6-week visit, this is like the critical one, right? Like, you got to see how you're doing. Like, this is trajectory for the rest of your thing. And you slack off there, it's kind of, those people come with a stiff shoulder at 6 weeks. They're not going to be the same as your person that comes in there trying to go crazy and they feel really good already. They've worked their shoulder a bit more with PT or whatever. It's different animal than nutrition. But when did they stop the supplementation in this? Do you remember? Was it roughly a timeline?
This was 4 weeks. This was just 4 weeks. 4 weeks. So they gave the supplement day of surgery 4 weeks on, And again, there was other things they looked at. This graph we're looking at is just strength, looking at 2 years, but the group that supplemented for the 4 weeks did better in the early period by other metrics.
So you would say in this case that basically they may not have seen the strength difference, because at 4 weeks is hard in general with pain and recovery, but that basically this is sort of like one of those sneaky ones, right? Where like you're really going to notice like you're basically at detriment, you don't even realize it, and you're so down that basically like you've built this sort of background information, background strength that's really not going to show itself until the 2-year mark, which is fascinating because I haven't seen a slide like that before and looking at all the nutrition stuff. So it's really interesting to see.
Yeah, it's really interesting. I mean, there's a question of period. I mean, some people say, load a couple weeks in advance, take a couple, 2 to 4 weeks after. There's some data that suggests after the first 3 months is critical, but I think the early period is probably the most critical. I think.
What's your recommended? Let's say, okay, Patrick or Dr. Denard, I'm seeing you. You're getting my shoulder surgery.
Yeah.
What should I don't care about. I don't care at cost. I don't care about stuff. What's the best thing I should do? What would you recommend?
Yeah, so I tell patients surgery. So I usually schedule out a few months, right? So I usually say, when I see them, I say surgery starts now, right? So I want you to start taking vitamin D right away, which is a month before surgery at least. But I start if they're 3 months in advance, I start taking it now. I have them load with protein.
Patrick, is that all patients or just your older patients?
All.
Got it. Okay.
I just don't see a downside for bone and muscle. There's good data for bone and muscle for vitamin D.
Sorry about that. I just curious.
And no, all good. So then I tell them to load with protein 2 weeks in advance of surgery. So they're basically doubling their protein intake to kind of load up.
Will, are you writing this down? Write this down.
This resonates because we had a similar conversation with Dr. Jazieri, and he was talking about the preload of the amino acids.
Yeah. He's a big advocate. He's a big advocate.
So a lot of the stuff that we're hearing, this is the way that everything's going, and I absolutely love it. It's just something that everyone should hear about this supplementation, getting ready before surgery and post surgery. So I hope people are just learning a lot. So I don't mean to interrupt you, but
keep going, Patrick. Keep going.
Prehab. Well, I'll just finish the protein thing. So load 2 weeks in advance. Continue. I want people to continue for 3 months afterwards.
Okay.
They should do a carbohydrate drink the night prior to surgery. You would never tell an athlete to run, a half marathon with not eating for 16 hours. We have patients do that all the time. So if you do a carbohydrate drink the night prior, there's good data that says they have faster recovery. And then I also think those other vitamin things are important. The vitamin D I mentioned, vitamin C very clearly helps decrease pain. It may help tendon healing, helps collagen production for wound healing. So all those things are really important. But I think, it's prehab in general. We're a little bit slow to this orthopedics. Other specialties have looked at this, but if you combine nutrition and the psychosocial preparation, which I try to do as well, it really matters. And we go back to that slide we talked about augmentation, but what's funny is when you really look at like the risk factors that were most important, like nutrition was a 300% increase in re-tear rate. We're not talking about
go to the
risk of re-tear, that you see with a large tear or a 30% higher risk. You're talking 300% increased risk of re-tearing when you have nutritional risk factors, which is, a very high percentage of patients, right? In this one here, it's 20% were the moderate risk. You're talking about really, really big differences that make an impact on people. So, I would argue if you're going to spend, $500 on PRP, a couple $100 in nutrition, your money's better spent. If I'm a patient and I have to pick, I want to do it all, but if I have to pick, my money is best spent on nutrition based on the data.
That is an absolutely excellent point, because I have probably the same as you, but you have various options afterwards that people can choose from beforehand, and they always or people come to the office, they're like, I want this or this, and I want this, and I don't want a budget, so I only want to spend it on certain stuff. So that's a really good important point to bring up, because I think it's like when we talk about surgeries, right? Like this part of the surgery is important. This is the extra credit part, right? We're going to try to do everything for you. The same way post-op, right? That people have to make choices. Some people don't care; they'll do everything, but that's not the way life is for most of us. And so as a result, the idea is that the nutrition, in your opinion, of all the things kind of post and pre-op extra, not, you know, you do your surgery, you do your patches, you do your biologics, or you do whatever you want to do. For you right now, priority is nutrition. Is that correct?
So I actually have now my instructions prioritize it, and I'll say here's tier 1, here's tier 2, here's tier 3.
Yes.
So for rotator cuff, let's say tier 1 is benzoyl peroxide, right? Low cost, lower the risk of infection, but that's all shoulders. Nutrition, and I like cold compression. Okay.
Cool.
My next thing that I say I would do if it's me but I would add PRP. Okay. And then if somebody really wants to get into it and they are in a cash pay situation, then I talk about BMAC, allograft augmentation, those kinds of things. But I think the biggest bang for the buck on the data is really those simple big things at the beginning.
Do you, in your opinion, do you think that the bone marrow aspirate is better than the PRP, or is it just that you kind of, the idea is there's obviously more potential mesenchymal cells in the
I think
BMAC?
there's potential higher concentration of growth factors, right? I don't think we don't know. We have 3 studies. We have one study from Hernigau, which said
that's it. Yeah.
We have Brian Cole's study, which, you know, it's really like you got to dive into the details to show a big difference. And then we have the database study that says there's a lower risk of revision. If people are kind of like, what do? I say, well, there's tons of evidence in PRP. You know, I would probably do that. But if it's a large or massive tear and they're kind of on the fence and they're interested in it, then I'm saying, you know, you're not going to be worse off with the BMAC. It's, you know, they're willing to spend, I'll do it for them. But PRP is a no-brainer for me.
Got it. This is awesome. Well, Will, do you have any more closing questions? As much, I told you I could do Patrick another hour, but I think that
and you Instagram, you go nerd it out. You went full nerd. I got important stuff. Like the fastest growing sport in the country is pickleball. What has Dr. Denard been dealing with and patient? Like, I've got good stuff here. You got too nerded out, Dr. Denard.
We just submitted a paper on pickleball, actually. Yeah.
We didn't even get
nutrition,
into the good stuff here.
PRP, he's got it, everything.
Yeah, that's funny.
Yeah, I know.
Hey, what's the future for you on this stuff?
Oh, future. I mean, shoulder arthroplasty, I'm really interested in getting to an optimized convertible glenoid. That's like, if I had one thing that I want to help develop and my last kind of thing in my career, that's what it would be.
Okay.
I think you're going to see you're going to see things like these algorithms that I took, and everybody's just going to have little machines that calculate stuff, right? As we have better data, because it's it went from differential diagnosis to algorithms to, it's going to be much more sophisticated individual decision-making. I think that is exciting. I think that is scary. Yeah, I think it's exciting because it kind of raises the bar for everybody, or raises the this playing field, where everybody can perform at a certain level. Because so many questions, as surgeons will ask, well, what do I do? Right? Because they don't have all this information in their head.
Well, they don't have the experience of the volume either that you have.
Yeah,
I mean, it's just a different animal.
Right. But what's scary is limiting our ability to do things. We talked about insurance early on, and you wonder, okay, are these guidelines, or these, it's the Gattaca movie, right? The guy who's he has the genetic disease and he can't perform, and of course he outperforms it. But we might get in situations where you lose the individual patient. So I'm a little nervous about that.
Got it. I want to ask you more questions about this, but we are at 1 minute and 15 seconds before our timer is up. Will, do you have anything else to add?
We got a Gattaca movie reference in. We didn't even get to if he's going to Coachella in 2026. I'm getting my tickets. So
I need another year off. Yeah.
I've got to go. It's on my list. If they come out May 2nd, Coachella tickets. So these are our priorities here.
You got to get those in.
But Dr. Denard, thank you so much for your time. I know we're wrapping it up here. Dr. Garcia, say something nice before we say goodbye.
Patrick, awesome. Thank you so much. Really great having you on. Thanks for showing your stuff. Anybody listening, Complete Nutrition is awesome. And you heard it from the expert right now. So thank you so much for everything.
Thanks, guys. It was very fun.
All right. Thank you.